Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. Today we're talking about BPH, which stands for benign prostatic hyperplasia, and we're going to talk about its treatments. So stay tuned. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. You know, we're part of the greater Clinic Review organization. Mark Klimek founded Clinic Reviews about 40 plus years ago. He is still alive, in case you're wondering. We offer online on-demand Clinic Reviews. It's an Nclex review. It is by far the best Nclex review out there, in my opinion. And it is taught by Mark himself. And Mark is a master teacher, and he also sees the world in patterns. And what he does is he reveals patterns to you so that you can better understand how things work together. And it doesn't require nearly as much memorization. You still have to have some memorization associated with it, but it provides an understanding of things in a way that you've never thought of before. So it's amazing, phenomenal. I highly recommend it. We also have small group tutoring that you purchase as a monthly package. And we have our streaming service, which has videos other than the tutoring and the Nclex review. So let's go ahead and get started. Now, benign prostatic hyperplasia, BPH. Hyperplasia is different than hypertrophy. Hypertrophy is an enlargement of the cells. Hyperplasia is a growth in the number of cells. Okay, so just so you know the difference between those things. So BPH is hyperplasia. It's a growth in the number of cells. So the prostate grows, and it's associated with increasing in age. In fact, I would go so far as to say 100% of men, if they live long enough, are going to experience BPH. So as the prostate grows in size, it presses against the urethra, and it prevents men from getting able to start their stream. They may have to try or stand longer waiting for that stream to start. They can have a forked stream. They can have urinary retention, which can lead to urinary tract infection. So the prostate doesn't cause the urinary tract infection. It's the pressing against the urethra that causes urinary retention that leads to urinary tract infection. So these are the problems. Sometimes it's associated with cancer. Whenever you see a growth in number of cells, you always say, well, is it malignant or is it benign? Malignant prostatic hyperplasia will be treated differently than benign prostatic hyperplasia. If it's benign, they may let it go for a while. They may try some other things to see if they can manage it. And then eventually they may choose to remove some of that prostate. So let's go ahead and get started. This does come from the Blue Book. The Blue Book is content that you need to know for the Nclex. You know that this channel focuses primarily on Nclex review. I do some lectures as part of this channel, but I also then add Nclex questions at the end of any lecture that I do. And so this is coming straight from the Blue Book. The Blue Book is content, factual information, and then I write questions that go along with the content so you can see how to use this information in an Nclex question. It's also good for HESI. It's good for any kind of standardized test that you take that's going to ask questions in a specific way. All right. Whew. All right, let's get started. Which of the following best describes the pathophysiology of BPH? Hyperplasia of prostate cells leading to urethral compression, inflammation of the prostate gland, malignant growth, atrophy. Atrophy is getting smaller, so definitely not that. Malignancy, benign. The B in benign prostatic hyperplasia stands for not malignant. Inflammation, it's not an inflammation. It's not a growth in the cells. It's actually an increase in the number of cells, which is hyperplasia. The nurse is assessing a patient for risk factors associated with BPH. Which of the following is considered a significant risk factor for developing it? Early onset sexual activity, high fat diet, low testosterone, or advancing age. Y'all, the number one risk factor for BPH is advancing age. Like I told you, about 100% of men going to get BPH if they live long enough. During a health history, a patient reports hesitancy in starting urination and a weak urine stream. Hesitation with urination is difficulty getting your stream started. Okay. So you've relaxed, you're ready for the urine to come out, and nothing comes out. And then a weak urine stream. Which additional question is the most important for the nurse to ask? So It doesn't say male patient here. I should have added that. I should have put a male patient reports hesitancy in starting urination and a weak urine stream, because if it was a female, I would ask a different question. Okay. So this would be a male patient. Do you experience any pain during urination? Have you noticed any blood in your urine? How many times do you wake up at night to urinate? Do you have any problems with sexual function? So if I had specified that this was a male patient, because hesitancy and a weak urine stream are associated with BPH, I'm going to ask about other BPH symptoms. And BPH does not cause pain with urination, and it shouldn't cause any blood with urination. It's just an enlarged prostate that's pressing on the urethra, which doesn't cause any bleeding, but it does often cause them to wake up multiple times at night to go to the bathroom because they don't actually empty their bladder all the way. And so they have to get up multiple times to go to the bathroom. A patient with BPH is scheduled for a prostate-specific antigen, PSA test. The patient asks why this test is necessary. What is the best response by the nurse? So when someone has an enlarged prostate, they're often going to do a PSA. In fact, I think they start doing PSAs on men starting at age 50, maybe a little later, depending, but it's probably around 50. Because it's such a common problem, they want to see if the PSA is elevated. So A, it measures the level of hormones affecting your prostate. No, it does not do that. It helps rule out prostate cancer as a cause of your symptoms. That's true. So if someone's having BPH symptoms, they do a PSA to see, because PSA goes up when it's malignancy, prostatic malignancy. It assesses kidney function to see if the BPH has affected them. No, that's BUN and creatinine. It detects any infection present in your urinary tract. Absolutely not. Doesn't do that. It does help rule out prostate cancer as the cause of your symptoms. Which of the following symptoms reported by a patient is most characteristic of BPH? Hematuria? No, it doesn't cause bleeding. Painful ejaculation? No. Flank pain radiating to the groin? No, that's urinary tract infection. Decreased force of urinary stream? Yes. A nurse is teaching a group of men about screening for BPH. At what age should men start discussing prostate health screening with their healthcare provider? So the answer is 50 years old. That's because it occurs with advancing age. That's when they start screening for an enlarged prostate. It's a digital exam. They go in through the rectum and they can actually palpate the prostate to see if it's getting bigger. And they can also do a PSA to see if that is going up. And the PSA goes up slightly with age anyway, but it doesn't, I don't think it ever goes up over 4, even with advancing age. A patient undergoing a transurethral resection of the prostate, transurethral, through the urethra, resection of the prostate. So it's actually a scope that goes in through the urethra, and they go in and they have to go through the urethra to get to the prostate, and they resect the prostate. So they're undergoing a Turp. They ask about possible complications of the procedure. Which complications should the nurse include in the teaching? Erectile dysfunction, urinary incontinence, chronic kidney disease, or increased fertility. So the answer, either you know it or you don't. The correct answer is urinary incontinence. And that's just because some of the muscles that help keep urine in the bladder are weakened with a Turp. It could affect erectile dysfunction, but it could cause erectile dysfunction, but it's much less common. So we do not tell people, men, that you should expect erectile dysfunction after a Turp. In fact, we say you shouldn't really expect that after a Turp, but that would be something for them to talk about with their surgeon for sure to find out if that's an issue. But it's much less common than with a radical prostatectomy. A radical prostatectomy is actually done laparoscopically, not through the urethra. And they can go in and remove that. It's more likely to have erectile dysfunction with a radical prostatectomy. When assessing a patient with suspected BPH, which diagnostic test provides a digital assessment of prostate enlargement? All right, teaching you vocabulary here, y'all. Digital does not mean computer. That's not what it means. These are your digits right here. Digital, okay? Which diagnostic test provides a digital assessment of the prostate enlargement? Cystoscopy, transrectal ultrasound, digital rectal exam, or urinalysis? A digital rectal exam, which they do yearly with men over the age of 50. If you're a woman, you don't realize that men have to have a digital rectal exam done with their exams. They don't tell their wives or their special someones about it because they don't like to talk about it, but it is done starting at age 50. The nurse is educating a patient on lifestyle modifications to manage BPH symptoms. Which of the following should be included in the teaching? Select all that apply. Okay, lifestyle modifications. There's not a lot of lifestyle modifications to, like, you can't reverse BPH with lifestyle modifications, but you can manage the symptoms a little bit. And what are the symptoms? Well, urinary retention. Okay, so A, limit fluid intake before bedtime. Well, that helps you not have to get up so many times during the night to go to the bathroom. So that would help. Reduce intake of caffeine and alcohol. So caffeine blocks ADH, antidiuretic hormone. Antidiuretic hormone is what prevents us from diuresing. So if we block ADH, we diurese more. So caffeine and alcohol actually increase the amount of urine produced, theoretically. I don't know if that actually happens, but theoretically it does. So it would seem like it would be helpful if we reduce that. Increase spicy food consumption. No, that's not going to help anything. Practice time voiding schedules. I mean, that could help if you are concerned that you're having urinary retention and you want to prevent UTIs. You could schedule to go to the bathroom, say every 3 hours, every 2 to 3 hours to prevent urinary retention. That could help. Salt restriction. Salt restriction really doesn't help with BPH. There really aren't any nutritional necessarily lifestyle modifications. There is some thought that increasing physical activity can help. I don't know how that helps, but there is some thought that physical activity, limiting fluids before bedtime, limiting caffeine, practicing time voiding schedules, those are about the only ones I've ever heard of. The nurse is reviewing lab results of a 55-year-old patient with BPH. Which finding is most concerning and warrants immediate notification of the healthcare provider? So if you have repeated urinary tract infections or you have urinary retention, the possibility is that it could back up into the kidneys and could cause some damage. So one of the more concerning complications associated with BPH, untreated long-term BPH, is kidney failure. So when I see creatinine of 2.5, I think, oh, that definitely should be notified. Hemoglobin of 10.4. Hemoglobin of 10.4 is not low enough for us to notify the healthcare provider. If it was under 8, I would. Hemoglobin of 10.4, I would probably want to see a recheck of that to see how it's trending, but there's nothing about a hemoglobin of 10.4 that causes me to notify the healthcare provider. White blood cell 4.5 is the low end of normal, but again, not low enough for me to contact the healthcare provider. Prostate-specific antigen. I would remember that PSA, you want it to be under 4. Now, you want it to probably be under 2 if they're under the age of like 40, but I wouldn't remember that. I would just remember it should be under 4. Just kind of as a general principle. So PSA of 2.9 at the age of 55 is acceptable to me. So I'm not concerned about that. So it's the creatinine that I would be most concerned about that's associated with BPH. A patient is being evaluated for possible BPH. Which symptom is least likely associated with it? Least likely. So I'm looking for the symptom that's not associated with BPH. And I put this in here just so you could learn the signs and symptoms or the common symptoms of BPH. We've already had a question on this, so we're just going to review it, make sure you know it. Dribbling at the end of urination, that is associated with BPH. Burning sensation, no, that's associated with UTI, which is not the same as BPH. Intermittent urine stream, yes, that's BPH because of the compression of the prostate on the urethra. Sensation of incomplete bladder emptying, yes, it does. That does happen as well. So burning sensation is the one that's least likely associated with BPH. Which of the following is the most common complication of untreated BPH? Renal calculi, erectile dysfunction, bladder cancer, or urinary tract infections. And I've talked about this already. Urinary tract infections are very common because of the urinary retention. And what can happen, this doesn't have anything to do with BPH necessarily, but it is associated with BPH. Older men who have urinary retention can get urinary tract infections. And sometimes if they have enough UTIs and they last long enough, that bacteria can actually get into the prostate. And once it gets into the prostate, it's very difficult to treat. And they actually can become septic. It's called urosepsis. So urosepsis is something that I do watch for in older men who have repeated UTIs. But a common complication of untreated BPH is urinary tract infections. After undergoing a TURP, a patient is receiving continuous bladder irrigation. So one of the risks after a TURP, well, one of the problems after TURP is there is bleeding associated with that. Blood clots can end up clotting the catheter. So we use a 3-way continuous bladder irrigation catheter so that we are looking at the color of the urine. And just so you know, you have irrigation going directly into the bladder. And then you have the bladder emptying both urine and irrigation. So you have to keep track of how much irrigation is going in. So let's say in an 8-hour shift, 500 mils of irrigation went in. That went into their bladder, didn't go into an IV, y'all. Went into their bladder and irrigated 500 mils in 8 hours. And they had 750 mils emptied from the bag, the catheter bag. Well, if 500 mils of that is irrigation, that means they only had 250 mils of urine out. So just make sure if you're asked about urine output when someone has a continuous bladder irrigation, you have to keep track of how much has gone in so you can subtract that from what you empty out of the bag so you can actually calculate the true urine output. All right. After undergoing a TURP, a patient is receiving CBI. The nurse noticed clots in the urinary catheter tubing. What would be the first nursing action? So this is a problem because it can obstruct the tubing. We don't want that to happen. Increase the rate of irrigation fluid, check for kinks, notify the surgeon, administer pain medication. So it's our job as nurses to run the CBI at a rate high enough that it keeps clots out of there. So we should be running the irrigation at such a rate that it keeps the urine flowing well, free of clots. That's our job. It's going to be pink because there is some blood in there. And if you see frank bleeding, like bright red blood, you do contact the surgeon. But clots are to be expected, and you want to run it fast enough that there's no clots and that the urine is just pink in color. The RN observes an LPN caring for a client after a perineal prostatectomy. Which of the following actions by the LPN requires the RN to intervene immediately? Immediately intervene. Whenever it asks a question where it says, when are you going to intervene immediately? What that always means is you see someone about to harm the patient. So if you intervene immediately with a student nurse, they're about to harm the patient. Intervene immediately with an LPN, they're about to harm the patient. So we're looking for something that could harm the patient. Now, the question is, what's a perineal prostatectomy? So they don't have to go through the urethra. They can go through the perineal area. They do make an incision and they go through the perineal area, and they can do a total prostatectomy, but you can't put anything in the rectum afterwards. And you don't want them to strain its stool. So you don't want them to be pushing, right? And so those are some things to think about after a perineal prostatectomy. All right, administering an oral stool softener. Well, an LPN can administer oral medications, and it's good to take a stool softener after this procedure because you want the stool to be soft. Measuring a rectal temperature, absolutely contraindicated. Changing the dressing. There is a dressing to change, and LPNs are allowed to do that. Encouraging fluid intake. Nothing wrong with encouraging fluid intake. There's no fluid restrictions. After surgery, of course, it's appropriate to encourage fluid intake. Not a problem with that. So it's the measuring of a rectal temperature that is absolutely contraindicated. We would need to intervene immediately. A patient is receiving continuous bladder irrigation after a transurethral resection of the prostate, TURP. The nurse notes that the urine output is less than the amount of irrigation fluid infused. Well, that's not good. What is the nurse's priority action? Okay, so the urine output is less than the irrigation amount infused. That means that means it's getting held up in the bladder somewhere. So I'm concerned the bladder is starting to become distended, which I do not want to happen at all. So should I increase the flow rate of the irrigation solution? No. Notify the healthcare provider immediately? Not yet. Reposition the patient to promote drainage? Maybe. Check the catheter and tubing for kinks or clots. Good idea. That's actually exactly what I should do Next, it's a priority. It's the priority at this time, and it's the next thing to do. So that's what I should do first for sure, because it's not draining. I mean, if the what's in the bag is less than what you've put in, then it's not draining. You got to look for kinks or clots. The nurse is preparing the irrigation solution for a patient undergoing continuous bladder irrigation post-TURP. Which solution is most appropriate? Sterile water, normal saline, dextrose 5%, or LR? The correct answer is normal saline. So that's something you'll just have to memorize. It's just a fact that you'll need to know. That's what we use for continuous bladder irrigation. A patient complains of bladder spasms following TURP surgery. Which medication should the nurse anticipate administering? Belladonna and opium suppository, acetaminophen, oxybutynin, or ibuprofen. So you just have to know this. We usually treat with belladonna and opium suppository, B&O suppository. And they've had a TURP, so they can get a suppository, y'all. This is not a perineal prostatectomy. This is a TURP. We went through the urethra, so they can get a suppository. This is what is used. I don't know why, but it's what's used to treat bladder spasms after TURP surgery. So if you're stopping spasming, that means you're decreasing the excitability of the bladder itself, right? And they've got a catheter, so it's fine because we're draining the bladder. But what is the problem that could happen? The nurse is educating a patient on the use of B&O suppositories after prostate surgery. Which side effects should the nurse be instructed to report? Dry mouth, blurred vision, constipation, or difficulty urinating. So if they are still getting these B&O suppositories after we remove the urinary catheter, they could have difficulty urinating, because what it's doing is it's decreasing the activity of the bladder that's used to contract the bladder, right? If you're decreasing spasms, and you're going to have some trouble contracting. So it would make sense that after taking a B&O suppository, if you don't have a catheter in, you could have some trouble urinating. The nurse is setting up a 3-way Foley catheter for a patient after TURP. What is the primary purpose of the third lumen in this catheter? So most catheters have 2 lumens. Hopefully you remember that. It has the lumen that you use to inflate the balloon, and then it has the lumen that actually drains the bladder. Okay, and you hook up the bag to the other lumen. So they all have 2 lumens, the balloon and the drainage bag. So what's the third one? Well, in a continuous bladder irrigation, the third one is for the irrigation solution. So this, and you put it, it's just run in by gravity. So you hang this solution up, so by gravity it goes into the bladder, and then it removes it by gravity through the normal bag that it has, and you use normal saline as the solution. What's the rate you run it in? You run it in at whatever rate is necessary to prevent clots and to allow the urine to be considered just a pink color, a light pink color with no clotting. And so that's how you regulate the rate, and it's just gravity. So you just up and open it or close the roller clamp as necessary to make sure you get the outcome that you need. A patient who has undergone a prostatectomy is being taught perineal exercises. So I'm going to assume they had a perineal prostatectomy. Which instruction should the nurse include? Contract your pelvic floor muscles as if you're stopping urine flow. Hold for 5 seconds and then relax. Perform sit-ups to strengthen your abdominal muscles twice daily. Engage in deep breathing exercises to enhance circulation. Practice leg lifts to improve lower extremity strength. So after perineal prostatectomy, they do have to do what women consider Kegel exercises to strengthen the pelvic floor muscles. And so men do Kegel exercises after perineal prostatectomy. Women do Kegel exercises after delivery of a baby, or when they're old and they're having trouble with urinary retention. They're not having trouble with urinary retention. They are losing urine without intention. Okay, so that is BPH. Hopefully you remember that it's hyperplasia, which is an increase in the number of cells. It's a compression on the urethra, which causes symptoms that you would expect when you have something compressing on the urethra: trouble emptying the bladder, spiked stream, hesitation, retention, increased risk for urinary tract infections. If it's treated surgically, it's often treated with a transurethral resection of the prostate, which is then they have to use a continuous bladder irrigation for a day or 2 post-operatively to make sure it doesn't have clots and they don't have any bleeding or severe bleeding. Or it can be done using a perineal prostatectomy, where they just go in and remove and has an incision and everything. So, all right, thanks for watching. Have a great rest of your day.